So the first two things to realize is that the incidence of glaucoma, or how common it happens, goes up with your age. So even if you don't have it when you're 40, you can get it when you're 50, you can get it when you're 60, you can get it when you're 80. So the older you are, the greater risk you are at getting it. And the other really, really important factor is family history. So if there is a family history of glaucoma, you're 10 times more likely to have it than any other person walking on the street. So it's really important to get checked if there's any first degree family member. So that's a mum, a dad, or sibling that has it. But even lots of patients come and tell me, oh yeah, my cousin had it, my maternal aunt had it. So it's not that simple. We know the highest risk is if your first degree family member has it, but any family member can versus risk. Generally, we say that it's wise to get your eyes checked once a year with your optometrist from the age of 40 onwards. If there is a family history of glaucoma, and I usually say first degree or non-first degree, if you know when that person was diagnosed, it needs to be 10 years earlier. So for example, if your brother was diagnosed at 42, you need to get checked from age 32 onwards. The nice thing nowadays as well is once we establish there is a risk, so if you have a family history, we can actually do predictive genetic testing. Super duper easy. You first come for a consultation because genetic testing carries a lot of responsibility and counseling with it. So we do a baseline assessment to see whether you actually have any signs of glaucoma that have declared themselves, or if you're a suspect. And that actually puts the interpretation of the genetic testing in a different category. And so then we discuss the test with you. It's a little packet that we give to the patient. The patient swabs the inside of the mouth. It's a bit like a COVID swab, except not the one you jam down your throat. You swab the inside of your cheek. And then you go online, register the kit, send it off. It's all a very secure process. It's protected by Australian privacy laws, and all the data is kept on servers in Australia. So there's you don't have to disclose it to anyone. There won't be discrimination. And this gives us a percentage risk score. So it tests all your genetic material for 7 million variants of genes that can cause glaucoma. And some of them are more benign ones, like I said before, they cause the piddly glaucoma, and some of those genes cause the bad glaucoma. So that gives us information that if you have family history, you don't have any signs yet, but your percentage risk score is low, then we can sort of relax and say, okay, let's screen you every 2 years. Whereas if the percentage risk score is high, then I might say, oh, let's do surveillance every 6 months.
I raised my hand before because I've got a family member who's got glaucoma, so I might have one of the lucky tickets in the glaucoma draw. So I'll
Oh,
have to.
yes. Well, it's not, like I said, it's not all doom and gloom. Some of the genes are
Yep.
piddly. So that sometimes actually doing the genetic test can relieve a lot of stress and anxiety, because when you have information, that's power to intervene and do something about it.
For sure. Well, okay, so there's genetics. Are there any other risk factors that, that would lead someone to think they should get tested more frequently? So are things like, eye trauma or lifestyle choices? I mean, are there any other risk factors that that you think are worth noting?
Yeah, so anyone who has had a blunt injury to the eye, so like a direct force, even though it may have recovered and nothing has happened, it's a good idea to get screened once a year, because we know people who have had blunt force trauma directly to the eye are at risk of developing glaucoma in their lifetime. And again, that's a slightly different mechanism, but it still holds whether you go and get your pressure checked and get the screening test done, so we can pick it up as soon as it happens. So if the pressure rises, we can treat it before it does any damage to the nerve, and certainly before it does any damage to the visual field. Other things, to be honest, the strongest one is family history, but other things that can contribute to it are short-sightedness, diabetes, and we said before with normal tension glaucoma, if you've got things like migraine or sleep apnea or Raynaud's, where your hands go blue in the winter, those are all risk factors as well. If you have a thin cornea at the front of the eye, then your glaucoma may be not detected till earlier on, because the way we check the pressure is to apply an instrument to the front part of the eye. And if this part of the eye is thinner than usual, it's going to give us less resistance. So those are the main ones, really. But the strongest one, like I said, is family history. So, I wouldn't be telling every patient with sleep apnea to go out and get checked, but certainly there is an association.
Right. So you mentioned nearsightedness, so that I guess
Yeah.
myopia is almost epidemic proportions now, and so this is
100%.
like another issue that arises later in life from
Yes.
myopia, doesn't it? Yeah.
Absolutely. So there is a clear association with myopia, and that's twofold. One of them is because myopes, in general, not all of them, or short-sighted people, tend to have a thinner front part of the eye. So it might be that when you go to your optometrist and, as the pressure goes up, the pressure may be checked at 19, but because this is really thin, the true pressure in the eye might be 23, which is, a flag raised. So it won't declare itself, or we won't detect it till a bit later on. The other thing is short-sighted eyes are longer and is clearer, or the wall of the eye is thinner. And this has biomechanical implications on the nerve. So where the pressure, and this is a very simplified version of it, but where the pressure presses on the nerve like this, if the tissues are more bendy, there is more mechanical damage that participates in damaging the nerve. So that's certainly a way that it can affect it. And the other thing is, sometimes people who are short-sighted who have refractive surgery, we know that refractive surgery or laser correction thins the cornea a little bit. So we just have to be a little bit more careful with surveillance. So a little bit more careful. Even if the pressure is borderline 19 or something like that, then we may escalate them for a review with an ophthalmologist. So I guess we need to be more vigilant and not use that 22 as a hard and fast rule. Even if the pressure is like high teens, low 20s, they should probably get checked.
Okay. So thin corneas doesn't necessarily mean that you're more likely to get glaucoma, but it just means that it's more difficult to detect. Is that what you're saying?
100%.
Yeah. Okay.
You got it. Yeah.
And would that also say apply to somebody with keratoconus, because that's another condition that seems to be getting more awareness out there?
Yeah, definitely. So actually, I've done a poster at a conference about this before, because there's a particular patient that comes to mind, and the title of the poster was Keratoconus, Inconspicuously Under Pressure. And the reason is every time this patient came in, the pressure was measured and it was low. And because he was coming in for his keratoconus, this is at the public hospital, we were only using the eye care, which is the little instrument that just bounces on the front of the eye to check the pressure, which is not as robust, not as accurate, but it's a good screening tool. And when you're looking at patients for other problems other than glaucoma, and so it was kind of missed because his pressure was 16 and 16 and 16 all the time. And then suddenly his vision was worse than we would expect for keratoconus. And we started doing all the glaucoma tests, and we found that actually he has it. And the reason the pressure is so low in that circumstance is twofold. One of them is the cornea is thinner, as we've discussed. And the second one is biomechanical factors. So in keratoconus, the cornea is, for want of a better word, more bendy. And so it's easier to, depress it and get that pressure reading. And therefore, again, not much resistance is applied, both because of the thickness and the different biomechanical characteristics. And so it's a double whammy. You end up really under reading the pressure. So patients with keratoconus, we need to be extra vigilant in imaging the nerve, scanning the nerve, and not relying so much on the pressure.